publications. So without any further ado, Professor Lee, please.
Thank you for introduction. I'm Dr. Lee from South Korea. Today I'm gonna talk about how to treat the peripheral AVM with endovascular techniques. And I have nothing to disclose. Arteriovenous malformation can be defined as an abnormal vascular network with a direct communication between the artery and vein. They can make a very fast flow region. So since the most blood flow goes through the low resistance shunt, so normal capillary fell into the ischemia. And another important symptom is venous hypertension. It's like a cortical venous reflux in the intracranial AVM. The venous pressure can increase because the direct arterialized pressure affect to the vein side. So normal venous drainage can be affected, and so the venous ulcer or swelling and pain can occur. And finally, cardiac overload can be the most dangerous problem in AVM. The goal of the AVM treatment is improve the tissue perfusion and decrease the venous pressure and normalized cardiac function. And imaging study for AVM is very important. We usually use a Doppler ultrasound study. It can provide us flow dynamics of the high flow region. We can use the color Doppler imaging and flow pattern analysis. This is the typical flow pattern of low resistance shunt flow, and after the treatment, the shunt flow will turn into the normalized arterial flow. And we can differentiate which one is feeding artery and draining vein. Using the Doppler ultrasound, we can differentiate the more high peak systole velocity of the feeding artery, and this is the draining vein, more damped flow and less peak systole velocity. This is a very comparative concept in the same patient. And also it can be used as guiding technique with ultrasound. And CT and MRI is very useful to determine the extent of the AVM, and it can also provide broad information, especially when we use the MR angiography with a TR MRA technique. And also bone AVM is about 11% in our database. So detecting the bone AVM is very important to treat. So in detection of the bone AVM, CT is more better diagnostic modality. And we can use a flow control technique with a balloon catheter, direct compression, or BP cuff. And also we can use various embolism materials. We usually use ethanol and coils to treat the peripheral AVM. This is an example of the flow control technique. we can use a BP cuff proximal to the lesion. This is the control angiography. You can see the draining vein from the nidus. And this is the powerful injection. I push the contrast injection quite rapidly. Then you can see the connected normal finger artery arising from the nidus. And after BP cup inflation proximal to the lesion, and then using a slow infusion, we can determine the target injection speed of the ethanol. Then we can treat the focal lesion we want. However, ethanol is very dangerous drug, as you know, but it is very effective curative potential, and they destruct the endothelial cell and make intravascular thrombosis and make an intensive inflammatory response. So ethanol cannot be used in brain AVM. It is very painful, so we need general anesthesia. We can use up to 5 cc of ethanol with a single bolus injection, and then we need a 10 minutes interval because the pulmonary arterial pressure and cardiac heart rate should be normalized. Then we can use another shot, bolus ethanol injection. This is the Professor Do angiographic classification of the AVM. He announced this angiographic classification from about 2006. This is quite similar with the Hodart brain AVM classification. This is a recent version, and he sub-classified the type 2 AVM. And this picture shows how to treat the AVM with according to the angiographic classifications. We will see how to treat the AVM with according to the type. Type 1 AVM is very rare, and this is the fistula type, so just the embolization of the feeding artery or the venous sac is enough for the treatment. This is a type 1 renal AVM. You can see the large feeding artery and draining vein. We just use the coils to treat this type of the AVM. And this is another example of the type 1 fistula type. You can see the one feeding artery and dilated draining vein. In this case, we can use a few coil insertion, and this is the follow-up imaging. We didn't treat the enlarged draining vein in this type of the AVM. In this case, you can see the one single feeding artery and draining vein. This is the angiography at the tip of the feeding artery. You can see some parenchymal branch arising from the feeding artery. So in this case, I used the transvenous embolization like this, and there was no parenchymal infarction. Then how to treat the type 2 AVM? It accounts about 25% entire AVM. Type 1 has a single large draining vein. Type 2 has a venous sac with numerous small draining veins, and type 2C has a long segmental draining vein with multiple fistula around the draining vein. This is the embolization strategy, and this slide shows a typical example of type 2A pelvic AVM. You can see the large draining vein and large enlarged IVC. And we can use a direct puncture or transvenous embolization. In this case, I used transvenous coil embolization to occlude the large venous sac. We need many coils. In this case, I spent 74 coils. I didn't use ethanol in this patient. After 3 months later, the AVM was disappeared.
Very expensive.
This is another type 2A renal AVM. You can see many tortuous feeding artery around the region and one single draining vein. And in this case, I used the transvenous catheterization of the venous sac, and I pushed the just 5 detachable coils in this patient. And this is the follow-up images. All the tortuous feeding arteries shows spontaneous thrombosis after the venous sac embolization. This is the typical type 2B AVM. You can see the multiple feeding artery and venous sac and small draining veins. In this case, we can use a direct puncture of the region and put some coils, and we can use a small amount of the ethanol. Then the lesion can be cured. And also, in some case, like Dr. Luan presented, just ethanol is enough for this type of AVM. This patient visited our clinic, and she has a huge thigh AVM. And in other hospital, they performed intra-arterial particle embolization for the AVM. However, 1 year later, the AVM still remained. You can see elongated draining vein in here and numerous feeding arteries. This is the femoral angiography, and this is the deep femoral angiography. After direct stick and elongated venous portion was embolized with multiple coils, and we used a small amount of the ethanol. This is the completion angiography, and this is the follow-up CT shows no residual AVM in this patient. Type 3B AVM is quite challenging because it can make a very large fistulas and multiple fistulas. So the embolization target should be dilated fistula, and direct puncture technique is better than transarterial ethanol injection, and ethanol injection with coil embolization of the venous sac is more efficient because the large venous cavity should be filled with a coil. Then we can control the flow velocity, and ethanol can be effective at that time. Without coil embolization, fast flow, in the fast venous flow, just ethanol can dilute it and no destructive effect to the endothelium. This is patient reported from Mongolia. He has a huge type 3B AVM, and this is the initial angiography. It's a very aggressive one, and as you can see the angiography, where is the first visualized vein? Here is the vein from the fistula. So this is the type 3B AVM, and we target here first with a direct stick, and we put a 5 French catheter and push some coils and ethanol injection. And then this is the completion angiography. There's one large floating thrombus in the large venous sac. So we treated him with a IVC filter and started anticoagulation. And then this is the next session. Where is the next target? We targeted here. You can see the feeding artery and venous drainage. This is the vein part. So we targeted here, and we put some coils and ethanol. We blocked some part of the AVM like this. And this is the third session. Where is the next target? Here is some venous portion. We punctured here and put some coils and ethanol. And this is the fourth session of the treatment. We put more coils and ethanol injection. There is no residual venous flow in this completion angiography. So we removed the IVC filter, and the lesion was completely cured. And he sent us a follow-up CT image from Mongolia. The lesion was completely cured. And this is a similar case. As you can see, large multiple feeding artery and large draining vein. We targeted here for the first coil embolization. Like this, we put two 5 French catheters in here, and this angiography shows AVM itself. You can see the retrograde filling of the feeding artery into the draining vein. This is the rear face of the AVM. So we put the coils in here and ethanol injection. At that time, we used too many coils, and we used 15 milliliter of ethanol. And then this is the second session. We punctured another target, and we used just 7 milliliter of pure ethanol, and then we could control the early draining vein. So you can see the residual feeding artery around the AVM. At that time, we can use another ethanol injection in this needle, just 8 cc of the ethanol. We could control the patient with a multiple coil embolization first, and then we treated with a residual small slow flow lesion with a ethanol direct injection. And this is how we treat the type 3B AVM. Type 3A AVM is quite different. It has very small fistula, and this is an example. You can see the very small fistula in the shoulder AVM. In this type of AVM, we can use a diluted ethanol like this. Most of the AVM was treated, but skin necrosis was occurred, and the lesion was cured after a few months later. However, recently, Chinese group reported intralesional interstitial injection of the bleomycin for the low flow, early stage of the facial AVM. This is how to treat the interstitial injection therapy. It works. So this is an example of our patient. You can see some cutaneous AVM was markedly reduced with interstitial injection therapy. Bleomycin is an anti-cancer drug developed from Japan, and it usually uses lymphoma or testicular carcinoma. However, this drug was proven to be effective on the vascular anomaly. So this drug has the advantage of less swelling, and we can use it in the facial area. We also treated with a transarterial bleomycin injection in facial AVM. The effect was quite similar. And this is an example. You can see we can use a balloon catheter to decrease the inflow of the AVM with an infusion of more than 40 minutes. And this is a patient has a paranasal and upper lip AVM. With a direct compression, we can slow down the flow, and we infuse the bleomycin transarterially. The lesion was disappeared in this patient. This is my conclusion. Doppler US study and flow analysis are very important in AVM management, and pattern approach using the angiographic classification is very important in AVM. And venous access or direct puncture is better approach technique than transarterial. And finally, interstitial or transarterial bleomycin injection therapy may play a role in type 3A AVM. Thank you so much.